Hi guys, welcome back to Dr. Patil's video channel. And in this video module, we will be discussing about a little bit of introduction to spondyloarthritis, and then specifically we will be spending time on ankylosing spondylosis, right? Okay, let me start with defining what is spondyloarthritis, right? So when we say spondylo, obviously we're talking about the axial skeleton, right? Now, these spondyloarthritis are basically a group of rheumatological disorders that share certain common disease manifestations, or I can say clinical features, and they also share genetic susceptibility association, right? They share genetic association. For example, the typical examples for spondyloarthritis, one of the classical example is ankylosing spondylosis. The other example I can give you is psoriatic arthritis. The other example I can give you is reactive arthritis. Now, reactive arthritis and spondyloarthritis. What is genetic commonness here? They both have association with HLA B27, right? HLA-B27, right? That is one important point that bridges these disorders together. Okay. Now, recent classification of the spondyloarthritis basically takes into account the predominant joint that is affected, right? The main joint that is affected. If it is the axial joints, spine and related joints which are mainly affected, then we call it as ankylosing spondylosis. Like typically we call it as axial spondylitis, and the classical example for that is ankylosing spondylitis. On the other hand, if the joints that are affected are mainly peripheral joints, then we will be classifying them under this heading of peripheral spondyloarthritis. Classical examples for that include psoriatic arthritis, reactive arthritis, and IBD associated arthritis, right? These are the classical examples for that. Then we should also keep in mind that there is a significant overlap between these disorders. Means patients who are diagnosed with axial ankylosing spondylitis, later they may manifest with IBD, right? Then patients who are started with IBD, later they may satisfy the diagnostic criteria for ankylosing spondylitis. So there is a significant overlap, right? So the extent of overlap can be summarized by this image, right? There is significant overlap, right? Okay, axial, yes, predominantly it is the ankylosing spondylitis. Apart from that, there is an entity called non-radiographic axial spondyloarthritis, where there is no radiological evidence of sacroiliitis. When we say ankylosing spondylitis, most important thing here is sacroiliitis, right? So with the conventional radiological imaging, for example, X-ray, there is no radiographic evidence. But if you do a more sensitive radiological test like MRI, specific MRIs, we will be discussing about those. Well, that can pick up. Okay. Now, this peripheral spondyloarthritis, obviously examples include psoriatic arthritis, reactive arthritis, and IBD associated spondyloarthritis. Apart from that, there may be cases which do not typically fit into this, right? Then we call them as undifferentiated peripheral spondyloarthritis. You cannot say that this is yes psoriatic, or this is definitely reactive, or this is definitely IBD related, but it meets the basic other criteria for peripheral spondyloarthritis. Then we call them as undifferentiated. Right, so there are basically two groups, axial and peripheral. Then we have two relatively newer groups introduced, that is non-radiographic axial spondyloarthritis and undifferentiated peripheral spondyloarthritis. Okay, that is the basic thing. Now I have already told you that these are a group of disorders which are bound together by certain shared clinical manifestations and genetic association. So what are those shared clinical manifestations? The first point, there is male preponderance, right? Males are more affected than females. There is male preponderance, like an exception from other rheumatological disorders, right? Male gender is more affected than female gender. Okay. Then the second manifestation is that even when we talk about ankylosing spondylosis, the main joint that is affected is the axial joints, but even the peripheral joints are affected. Even in that case, the peripheral joints are affected. Okay, but that peripheral involvement is usually asymmetric. It is usually asymmetric lower limb large joint arthritis, right? So when we say peripheral, basically we are talking about lower limb more than upper limb and large joints more than small joints, right? Then the third characteristic shared feature is presence of sacroiliitis, right? Then they can have enthesitis. What is enthesitis? It is the inflammation of the insertion site of tendons and ligaments, right? When they are inserting at that point, there is inflammation, right? They can have dactylitis, and one more characteristic feature that is common across these spondyloarthritic conditions is uveitis. Uveitis is in fact one of the most common extra articular manifestation. Another thing that is shared by these entities is the negativity for Ra factor. That is why in the past we used to call it as negative seronegative spondyloarthritis, right? That was a terminology used in the past. Okay, so these are the important features that they share. Now coming to the most important feature that they share is all of these conditions have a tendency to occur in patients who are HLA-B27 positive, right? So in fact, if you talk about ankylosing spondylosis, 90% of the patients are positive for HLA-B27, right? 90% of the patients are positive for HLA-B27. Okay, that is about the genetic association. Now coming to the topic proper for the day, that is ankylosing spondylosis, right? What is this? Yes, this is a spondyloarthritis which falls under the heading of axial spondyloarthritis, right? The axial joint is more affected. Right. So remember, this is the most common inflammatory disorder of the axial skeleton. Okay, and if you look at the prevalence, right, there is a thumb rule. We say the thumb rule of 2. That is how I call it as thumb rule of 2. 0.2% of general population has ankylosing spondylitis. 2% of HLA-B27 positive population has ankylosing spondylosis, and 20% of the B27 positive HLA-B27 positive patients who have a family history of ankylosing spondylosis have ankylosing spondylosis, right? 0.2 to 20%. 2% of general population, 0.2% of general population, 2% of HLA-B27 positive population, and 20% of HLA-B27 positive family with a positive family history, right? That is the rule of 2. Okay, and obviously we have already discussed that males are more affected in all these all these spondyloarthritis conditions. So here also males are more affected. In fact, there is a significant difference, right? So there may be subtle variations between different entities under the heading of spondyloarthritis between the gender distribution, but in none of them have female preponderance, right? At best, there may be equal gender ratio, but none of them have female preponderance. On the other hand, like when we talk about other autoimmune disorders, yes, there is female preponderance, right? For example, rheumatoid arthritis. Now coming to clinical features of ankylosing spondylosis, right? The usual onset of symptoms is in young adulthood. Like you have a HLA-B27 and then you develop this clinical manifestation usually in the young adulthood. The main age of presentation is 25 years. Right? Mean age of presentation is 25 years. The most common complaint of these patients is in the form of low back ache. Right. For diagnosis, we need to have the history of low back ache lasting for at least 3 months in duration. Right. The most common presenting complaint is low back ache. Right. This is an MCQ point. Most common presenting complaint. Right. And because we are talking about an inflammatory disorder, right? We have already made that statement. This is the most common inflammatory disorder of the axial skeleton. So whenever we have an inflammatory arthritis, right, we have certain characteristic clinical features associated with it, right? So patients are going to have early morning stiffness, and this early morning stiffness is going to last more than 30 minutes. The early morning stiffness is going to last more than 30 minutes. Okay. Other than that, patients may have nocturnal low back ache. Now, whenever we say nocturnal symptom, that means it is a significant disorder. It is not going to be a simple functional disorder, right? All nocturnal symptoms are generally organic. Right? So patients may have low backache which is present in the night also, right? And because it is an inflammatory disorder, pain may become better on exercise, right? So they have worst pain in the morning, and as they progresses, their pain becomes better, right? Because you're talking about an inflammatory arthritis. If it was a non-inflammatory arthritis, reverse would have been true, right? The exercise would worsen the pain. They have a better morning and worse evenings, and the early morning stiffness in that case would be lasting for less than 30 minutes, right? But here it is an inflammatory arthritis, so early morning stiffness would be lasting for more than 30 minutes, whatever joints are affected, right? So mainly axial skeleton, so patients would experience stiffness of the spine in the morning, right? Difficulty to turn around because of the spine stiffness, and lower limb joints are more affected, so they may have stiffness of the lower limb joints, right? Okay, so that is one important clinical feature, right? Low backache, and that is because of the involvement of spine and the sacroiliac spine, right? And the sacroiliac joint. So when we examine, we have to examine for their integrity of the spinal structures and the sacroiliac joint. Okay. Now coming to the peripheral joints that are affected, right? We call it as axial because axial joints are more affected than peripheral, but that does not mean peripheral joints are not at all affected. They are quite significantly affected, right? I have already made this statement. When it comes to peripheral joint involvement in ankylosing spondylosis, lower limbs are more affected than the upper limb, right? So like lower limb joints are more commonly affected, mainly large joints. So we are talking about knee joints or hip joints, right? Large joints are more affected than small joints. Okay. And one particular important thing in the history you should note is whether there is history of tendinitis or heel pain in the past, because that suggests patient might have gone through enthesitis and plantar fasciitis, right? All these are pointers towards enthesitis, and enthesitis is one of the characteristic finding associated with spondyloarthritis, right? What is enthesitis? Inflammation of the tendon insertion points, right? Okay. If there is a long-standing history of spondyloarthritis, patient may develop a forward stooping posture, like you can see from this image, right? Forward stooping posture, right? This can be assessed by taking a chin brow to vertical angle, CBVA, right? This is a line which goes from chin to brow, and then we have a vertical line. This angle is usually more than 30 degrees, right? Okay, so that is about the posture. Now coming to extra-articular manifestations. So articular manifestations we know it's inflammatory arthritis, early morning stiffness, axial skeleton more affected, lower limbs more affected. Now coming to extra-articular manifestations. The most common extra-articular manifestation is basically anterior uveitis, right? It is known to occur in 40% of the patient. To be very frank, we should be calling the IBD as the most common extra-articular manifestation, because histopathologically you can prove that it is there in 60% of the patients, but in reality it is mostly asymptomatic. So they do not manifest with the bloody diarrhea, abdominal pain and all. Only if you do biopsy, well, it might say that there is IBD. So I wouldn't be calling it as the most common, right? And even the textbooks continue to describe anterior uveitis itself as the most common extra-articular manifestation, right? Usually when the anterior uveitis occurs, it is usually unilateral, right? And it is known to recur, and recurrence usually affects the other eye, right? You start with the right eye, you have anterior uveitis of the right eye. Now you develop pain, photophobia and lacrimation. Those are the classical symptoms. You get treated with steroids, topical or systemic, you get better. When it recurs, it is going to recur on the other eye, opposite side eye, right? So recurrence is known to occur on the opposite side eye. Okay, so this is an MCQ point, right? This is the most common extra-articular manifestation. Okay, other than that, yes, patients are known to develop the iotitis, right? This is also known as this can also lead to aortic regurgitation. So they can develop iotitis, which can go on to cause aortic regurgitation. They can develop conduction defects. So it is not surprising to see a third degree heart block in these patients. Okay. Then these patients can develop asymptomatic mucosal lesions. I have already told you about this, right? Involving the terminal ileum and proximal colon. And 10% of these patients, if you do histopathology, yes, pathologists may say that they are having IBD, but they are clinically usually silent, so we don't call them as having IBD. But 10% of these patients go on to develop frank clinical IBD over their lifetime, right? So there is a high risk of progression to inflammatory bowel disease. Other manifestations include IgA nephropathy and renal amyloidosis. So these are the extra-articular manifestations. Okay. Now coming to the physical examination. So what we should be examining, basically we know that these patients have the axial skeletal involvement and peripheral joint involvement. So we have to test for the spine, we have to test for the sacroiliitis, we should look for the evidence of inflammatory arthritis on the peripheral joints, we should look for the extra-articular manifestations, right? Mainly anterior uveitis. So let us start first by understanding the spine mobility, right? Because these patients have restricted spine mobility and which can be assessed by Schauber's test. I think one of those tests which is very, very famous and known to all medical students, right? Then sacroiliitis can be identified by presence of joint line tenderness. So obviously you can elicit tenderness. And there are two maneuvers. One is Febvier test, right? It's known as Febvier's test, or probably some of you recognize it as Patrick's test from orthopedics. Right? And Gainsland maneuver. I'm not sure if it is pronounced like that or whether you want to call it as Gainsland maneuver or Gainsland test. Yeah, that is one another test which helps us to identify sacroiliitis. That basically we put some stress on the sacroiliac joint to see if the pain or tenderness is triggered there. Right. What do we do in Schauber's test? In Schauber's test, first we go to identify the fifth lumbar spinous process, right? And we draw a line there. Right? We identify the fifth lumbar spinous process. We draw a line there and then go up by 10 centimeter and make one more line. We ask the patient to bend forward as much as he can, right? So this line, which is we have drawn at a distance of 10 centimeters, if the person is having normal spine mobility, when he bends forward, it should increase by 5 centimeters more, right? It should become 15 centimeter normally. If it has not become 15 centimeters, say it is 13 or 14 or 12, that means there is reduced spine mobility, right? That goes on to say that patient may be having ankylosing spondylitis, right? So we are expecting it to increase to 15 centimeters or more. Okay, that is Schauber's test. Then we also have a modified Schauber's test. Modified Schauber's test. Okay, what do we do in modified? In modified, instead of only drawing one line at L5 spinous process and one line at 10 centimeters above, what we do is we draw two lines, one 10 centimeter above the L5 spinous process, another 5 centimeter below that, right? So we will have two lines. One, this is our L5 spinous process. So one 10 centimeter above that, one more line 5 centimeters below that. So the total length that we have at the start is 15 centimeters, and when patient bends forward, we are expecting it to increase by 5 centimeters more. So it should become more than 20 centimeters, right? It should become 21 centimeters or more than that. That is modified Schauber's test, right? Both of them are methods to assess the development of spinal immobility or reduced mobility, right? If they are not achieving 5 centimeter increase, that means there is immobility. That is Schauber's test, right? Okay. The next test is Febvier test or Patrick test, or this is also known as figure of 4 test. Okay. Febbier's test in itself is a mnemonic, right? The real name of this test is actually Patrick's test. Okay. What do we do in this test? We ask the patient to lie supine on a flat surface or on the examination table, right? And then we put his leg in the figure of 4 position, like you can see here, right? So here what we are doing is like this limb we are examining, or this hip we are examining. So we are doing a flexion of the hip, right? First thing we notice is that there is flexion of the hip, and then we are doing abduction and external rotation, right? That is what is Febvier: flexion, abduction, external rotation of the hip, and then extension of the hip, right? These are the steps that are going behind creating this figure of 4. So the patient's ankle of the side that is being tested is now resting on the opposite limb, and we are applying pressure. So this pressure application is going to extend the hip joint, right? Extend the hip joint, and we are also applying pressure on the opposite hip, right? When we do this, right, a patient experiences low back pain, right? That basically goes on to say that patient has sacroiliitis, right? We are putting the patient in figure of 4 position. That is why this is also known as figure of 4 test. Patrick test, Febvier test, or figure of 4 test, one and all same. And this is a clinical test for assessing the sacroiliitis. There may be other utility of this. Probably orthopedics guys know better than us. Okay, the last clinical test that we should know is the Gainsland test. So in this test, what we basically do is we put the patient supine on a examination table, and the side which we are examining, we bring it to the edge of the table. Like you can notice here, he's on the edge of the table. He's hanging the limb down from the edge of the table, and the examiner is putting pressure downwards so that the hip hip joint is extended, right? So this hip joint on the side where we want to test is extended. On the other side, he is also flexing the knee joint and pushing it retro, right? So he is basically making the hip maximally flexed on the other side. So on one side, the hip is maximally flexed, and on the other side, hip joint is maximally extended, right? This puts pressure on the sacroiliac joint, and if there is sacroiliitis, this would trigger the pain, right? So these are the three tests for us to remember. Test number one, Schauber's test, very famous, well known to all of you. Test number two is Fabier or Patrick's test or figure of four test. And test number three, Gainsland test. Now the test number one, Schauber's test. This we did to assess the, why did we do this? To assess the spine mobility, right? Whether it is flexible or not. But the other two tests were basically trying to demonstrate that patient has sacroiliitis, right? We're trying to trigger the pain. Okay, that is the physical maneuvers. Now coming to investigation or imaging. Imaging is must because radiological evidence of sacroiliitis is must for the diagnosis of ankylosing spondylosis. Right? If it is not there, we would be calling it as non-radiographic axial spondyloarthritis. Right? So routinely performed investigation is basically X-ray. Usually we do a X-ray of the pelvis with hip joint AP view. Why do we do with hip joint? Because good number of these patients also have hip joint arthritis coexisting. I have already told you lower limb joints, large joints are more affected than upper limb. So knee arthritis as well as hip joint arthritis is very common by the time we diagnose the patient. Right. So presence of sacroiliitis definitely is the hallmark of ankylosing spondylosis. Right. It is must for us. And we should know the grading of ankylosing spondylosis, I mean sacroiliitis, on the X-ray. Right? So there are four grades basically, where the grade 0 means normal, grade 1 means it is like suspicious sacroiliitis, grade 2 means there is some degree of sclerosis. Right? So there is usually subchondral sclerosis when these patients have the inflammation, and there may be some degree of erosions. In grade 3 there is severe erosions, but there may be joint space widening, which as it progresses causes fusion, right? This is actually a pseudo joint space widening, and some degree of ankylosis, right? That means some degree of joint fusion. In grade 4 there is complete ankylosis or complete joint fusion, right? I will take you through images, right? See this image number 3, right? If I can zoom you and show clearly, that you would notice that you can still identify the joint line, right? So there is some degree of joint fusion, but not completely fused. So that means some ankylosis is there, but not completely fused, right? You can identify joint lines here and there, and there is also slight widening, right? But there is also fusion at some places. So when there is some fusions, then we would be calling it as grade 3, right? That is what we agreed upon. Some ankylosis, that means it is joint 3. There may be joint space widening associated, right? That is grade 3. This typically fits into that. You can probably agree with me that there is joint space widening in this area, right? And in this area there is fusion or ankylosis, right? Now let us go through one more image, right? So here is another image. Literally we cannot tell where the sacroiliac joint is positioned, right? It is almost blurred because there is ankylosis or fusion. Difficult to say or pick up the joint line, right? So that is why this is grade 4. So in grade 4 there is complete ankylosis, and in grade 3 there is some degree of ankylosis, and it may be associated with joint space widening. And that is the grading of sacroiliitis on X-ray. Now why this is important? Because that grading is utilized in the diagnostic criteria or the classification criteria. Okay. Now that was about the sacroiliac joint. Now we know that it is axial skeleton which is affected. Apart from the sacroiliac joint, there may be involvement of the spine, right? So for that we can do a vertebral X-ray, or you can go with CT. On X-ray and CT there are some important named imaging findings, so we should be knowing them, right? The first one is shiny corners. This is also known as Romanus sign or Romanus sign, right? What is shiny corners? You can look at the image number 1, right? The corner of these vertebral bodies, corners, they are shiny, right? Like some illumination is there underneath them, right? This is what is known as shiny corner. You can appreciate on these images also if it is clear to you on your screen. Maybe it is little more clear here, right? And it is definitely very clear in this portion, right? can literally see that the corner is very shiny, right? What is this known as? This is known as Romanus sign or shiny corners. Okay. Then the second important radiological finding that we can get is squared vertebrae, right? Squared vertebrae. What is squared vertebrae? Squared vertebrae is basically a situation where, see, normally the vertebral column, when you see lateral x-rays, the anterior side is concave, right? In fact, in this image also you can appreciate, right? The anterior side is having some degree of concavity, right? When this concavity is lost, then the vertebral bodies look like they are squares. That is what we call as squared vertebrae, right? Let me erase this thing that I had made for you to identify, and now it becomes very clear, right? Squared vertebrae, they are literally assumed a square position. Yeah, the anterior border is very straight, right? Now you can make a square boxes there. That is what we call as squared vertebrae. Okay, that is another finding. So we have two important signs to remember now: Romanus sign or shiny corners, and the second one is squared vertebrae. Okay, the third thing is something known as syndesmophytes. These are not osteophytes, right? They are called as syndesmophytes. What are syndesmophytes? These are nothing but calcification of longitudinal ligaments. Okay, longitudinal ligaments, they get calcified, then we call them as syndesmophytes. Now when these syndesmophytes fuse with adjacent vertebral bodies, right, then we call them as bridging syndesmophytes, right? Then we call them as bridging syndesmophytes. So finding syndesmophytes is almost characteristic of ankylosing spondylitis. Okay, then the last radiological finding, something which I'm sure that you are all very much familiar with, frequently asked MCQ point: bamboo spine is seen in which of the following condition, right? Bamboo spine is seen in ankylosing spondylosis. What is bamboo spine? There is ossification or calcification of intervertebral discs, right? So you can appreciate the calcification of intervertebral disc, and because of that, when you look at the spine on the X-ray, right, it looks like a bamboo, right? It looks like the bamboo tree or bamboo, right? That is why this is known as bamboo spine. So bamboo spine sign is because of the ossification of intervertebral discs. Okay. Now coming to the next important investigation that we should be doing, that is MRI. Okay. Now X-ray is a good investigation if you have obvious findings, but in the very early stages you may not pick up any changes. The inflammation of sacroiliac joint may not be evident in the early stages, but MRI is something which can pick up. But again, let me remind you that the conventional MRIs which are routinely prescribed for low backache are not helpful in identifying early changes of ankylosing spondylosis or sacroiliac inflammation, right? So what helps us really pick up the early diagnosis is to do a stir sequence, that is known as short tau inverse. Okay, short tau inverse ratio imaging, right? Short tau inverse ratio imaging, or you can go for a T2 weighted image with fat absorption. This is one of the MRI imaging sequences. You have to either go with STIR or T2 with fat absorption MRI. Those two can identify bone marrow edema. That is the earliest. This is the earliest and also the most specific finding suggestive of the sacroiliitis on MRI, and this can be a radiology MCQ question, right? Most specific MRI finding as well as earliest MRI finding on in a patient with ankylosing spondylitis when we are talking about sacroiliitis, right? So this is one point to note. Now coming to differential diagnosis, there are two important differential diagnoses I want you to remember because they have a little bit of a similar radiological presentation. The first one is DISH. Okay, DISH stands for diffuse idiopathic skeletal hyperostosis, right? This is basically a disorder of elderly people, very often diagnosed after 60 or 70 years. On the other hand, ankylosing spondylosis is usually diagnosed before the age of 45 years. Right. It is not diagnosed as an important DED when patient presents after 45 years with low backache. Right? It is kind of like we are not considering that in the diagnosis. Right? Because this occurs in elderly people, it is not very closely related differential. But if you see an image, there is calcification of the longitudinal ligaments. So patients may present with a very similar looking looking X-ray. But there is some important differences also. The difference is that there will be no sacroiliac changes in dish, right? That is one radiological differentiation point. History per se, the dish is rare before 45 years, while ankylosing spondylitis is rare after 45 years. Presentation after 45 years is rare. Okay, so this we can easily differentiate, right? Then just because we're talking about it, I will tell you one important radiological sign that you should remember, that is known as flowing wax sign. Okay, after the session or after the class, just you guys google it out and you will be able to pick up an image of a flowing wax sign, right? Or flowing candle wax sign. Okay, now second differential diagnosis is SAPHO syndrome, which actually stands for synovitis, acne, pustulosis, hyperostosis and osteomyelitis. This is also not very difficult to distinguish because it has certain characteristic associations, right? Acne, pustulosis, osteomyelitis. So this is also not very difficult to distinguish, right? Radiologically, yes, these are conditions which come close to the diagnosis of ankylosing spondylosis. Okay. Now coming to the definitive diagnosis. So far we spoke about differential diagnosis. Now coming to a confirmatory diagnosis, right? So diagnosis is obviously based on clinical context, but most of the practitioners continue to believe or follow the classification criteria put out by ASAS. So we follow ASAS classification criteria for axial spondyloarthritis. Right? What is the classification criteria? According to the classification criteria, axial spondyloarthritis is considered in a patient, right, who presents with back pain with a duration of more than or equal to 3 months and the age at presentation is less than 45 years, right? Remember 45 years. I am stressing upon it. Why am I stressing upon it? Yes, we were discussing about one differential diagnosis, right? Dish, which is rare before the age of 45 years. On the other hand, technically we can't classify a case as having spondyloarthritis if the age at presentation or age at onset is more than 45 years, right? Because classification criteria specifically mentions about it. So when anyone less than 45 years presents with low back ache lasting for more than 3 months, we would be considering or classifying the case as spondyloarthritis, axial spondyloarthritis, if patient has at least one, on imaging there is evidence of sacroiliitis and has at least one spondyloarthritis related clinical feature. But if radiological evidence of sacroiliitis is not there, right, then we are looking at HLA-B27. So if patient is HLA-B27 positive, then we need two spondyloarthritis feature. So if there is imaging evidence, then one is enough, kafi hai. If there is no imaging evidence, but you are going by the genetic evidence, then you need two clinical features. Okay. What are the spondyloarthritis features that this classification criteria talks about? Inflammatory back pain, right? So they're using the word inflammatory. That means the back pain should be worse in the morning. There should be early morning stiffness lasting for more than 30 minutes and exercise should improve the stiffness and pain, and movement should improve the pain, and in fact they should feel better by evening. Morning should be their worst days, right? Then it may be associated with other peripheral arthritis, right? Enthesitis, particularly heel, right? I was already telling you about the heel pain, right? If patient had plantar fasciitis, that may be a pointer towards enthesitis. Then uveitis, we already know now that it is a most common extra-articular manifestation. Dactylitis, having psoriasis, Crohn's disease or other colitis, or there is history of good response to NSAIDs. NSAIDs are the mainstay of treatment for ankylosing spondylosis. So if patient was taking NSAIDs and feeling really better with that, well, that is also one of the clinical features. Then having HLA-B27 positivity or elevated CRP, right? CRP and ESR, not always, but in a reasonable number of patients are elevated. Okay. Then if patient has HLA-B27 positivity, right, if this is positive, then he should have at least two of these to be classified as ankylosing spondylitis or axial spondyloarthritis. If we have done a X-ray of the hip joint and sacroiliac joint and we know that there is inflammation there, then any one of this additionally present, right, that is more than enough. But this sacroiliitis imaging has certain characteristic criteria to be satisfied. Okay. So when we say imaging evidence, it means MRI could be used, right? Obviously MRI is very sensitive, very specific, and it can do early detection. You can use MRI, but if you're not using MRI, rather you are using the X-ray, right? then we have to make sure that the sacroiliitis is according to modified NY criteria, right? So what is modified NY criteria? Modified New York criteria says that the relevant sacroiliitis on imaging is when it is bilateral and it is grade 2 to 4. Bilateral 2 to 4, or if it is only unilateral, normally it is symmetric bilateral, but when you are doing an imaging, if it is unilateral, if it is grade 3 to 4, and if it is grade 3 to 4, that satisfies the radiological criteria to call it as having sacroiliitis on imaging, either MRI evidence or X-ray, unilateral grade 3 or 4 and bilateral grade 2 to 4. Okay, what is that grading system? We have already discussed about the grading, right? This, right? 2 means sclerosis, some erosion. 3 means severe erosion, joint space widening, and some ankylosis. 4 means complete ankylosis, right? So if patient is having bilateral, right, 2 is also enough, right? 2 is also enough. If patient is having unilateral, it should be 3 or 4. Okay, so that is about the classification criteria, right? So remember basics about it, right? Patient with sacroiliitis on imaging should have at least one spondyloarthritis feature, and if that is not there, if you are going by HLA-B27, he should have 2 spondyloarthritis feature. Okay, now you know the diagnostic approach, right? So now let us talk about the management. Okay, management, yes, we should strongly encourage the patient to take good time for exercise and back extension, because the most common bothersome complaint is stiffness of the back. So back extension we should encourage exercises. We should encourage swimming is considered as a good exercise for the axial skeleton, right? Why are we encouraging the exertion? Because this is an inflammatory arthritis, right? Exercise improves their symptoms, so they also feel better, and the joint and the muscle integrity is maintained well when we subject them for exercise. So we should push them for tolerated exercises. And when it comes to drugs, right, NSAIDs are the mainstay of treatment. I have already mentioned it here, right? They are the go-to drugs. Usually we prefer to use good potential NSAIDs like indomethacin or naproxen. If patient has GI intolerance, ulcers or something, you may consider COX-2 inhibitors. I wouldn't be personally very much worried about the cardiac complications of COX-2 inhibitors, because we're talking about population which is usually less than 45 years, right? Until and unless there is contraindication, maybe it's wise to consider COX-2 inhibitors if the conventional NSAIDs are creating side effects in them. Okay, if that is not helping, right, or if patients are not achieving good disease control, then you can think of the disease modifying agents. The commonly used disease modifying agent is sulfasalazine, which is used in dose of 2 to 3 grams per day. 2 to 3 grams per day. But unfortunately, it has limited benefit in case of ankylosing spondylitis. This has more utility or more benefit, disease modifying agents, when we talk about peripheral spondyloarthritis like psoriatic arthritis, right, or reactive arthritis. There it is more helpful, but nonetheless, if NSAIDs are not adequate, maybe we can add them to get the added benefit. Okay, the next level of management basically comprises of TNF alpha inhibitors. TNF alpha plays a role in the pathogenesis, so the next level of management basically relies on this. Okay, when is it indicated? We guys already know the examples, right? Infliximab, golimumab, certolizumab, and etanercept. We should know one important side effect of this, that it can cause reactivation of tuberculosis, right? So someone who has having a tuberculin skin positivity, skin test PPD positivity of more than 5 millimeter, generally they say that avoid this drug, or first treat them with ATT and then start the drugs. Okay, when is it indicated? It is indicated in patients with ankylosing spondylosis with peripheral arthritis, which is refractory to sulfasalazine. And when I say peripheral arthritis, right, when there is peripheral arthritis, that responds well to sulfasalazine, right? More useful when there is peripheral symptoms. So if you have a AS patient who has peripheral symptoms, and despite giving sulfasalazine, he continues to have disease activity, yes, in those patients you can consider anti-TNF alpha therapy. And those patients of AS who remain uncontrolled, or whose disease activity continues to be high despite 3 months of NSAID treatment, right? In those patients also you can consider anti-TNF alpha therapy. Okay, I hope you got the point, right? Now we have some reserve drugs which are used when the TNF alpha therapy fails, right? Those include ustekinumab, which is a anti-interleukin 12 and 23 antibody, right? Remember this because we talk about it in rheumatoid arthritis and in various other autoimmune disorders, right? Then we have one more newer monoclonal antibody, which is known as secukinumab, which is a anti-interleukin 17 alpha receptor, anti-interleukin 17A receptor. This is reserved when TNF alpha therapy fails. We think of these drugs. Okay. I don't think the doses and the schedule of administration is particularly important for the undergraduate students. So I think this is fair enough of information for us to get prepared for the upcoming examinations. So with this, we will wind up today's session. We will be doing similar sessions on rheumatology. Whatever topics that I had promised us and are spending will be covered in next 1 week's time. Hopefully that helps you. Right. Thank you guys for connecting.